step-by-step method that is typically used for identifying the potential cause of abdominal pain or discomfort. First and foremost, it is important to take a thorough history. And so it is important to ask the patient about the onset of the pain, whether the pain was sudden or gradual. Also the location of the pain. Where is the discomfort happening? Has the pain moved to other parts of the body? Ask about the character of the pain. Would the pain be described as sharp, dull, cramping, or burning? Does the pain also move to the back, shoulder, or groin? So that's inquiring about the radiation of the pain. Also ask the patient to rate the severity of the pain from the scale of 0 to 10. 0 being minimal pain, 10 being the worst pain that they have ever experienced. And then of course, ask about the timing. Has the pain stayed constant? Has it waxed and waned? Has it gotten worse? And speaking of the pain worsening, ask about aggravating or relieving factors. Does the pain get better or worse upon eating, movement, or medications? And then you also want to ask whether the patient is was also experiencing nausea or vomiting, diarrhea or constipation, fever, chills, weight loss, jaundice, or the yellowing of the skin and eyes, or urinary symptoms such as dysuria, polyuria, oliguria, etc. And then for female patients, ask about their gynecologic history, ask about their last menstrual period, and about the possibility of that they could be pregnant. And then, when inquiring about past medical history, ask about previous surgeries, especially in the abdominal area. Ask about any gastrointestinal disorders they currently have, like inflammatory bowel disease, gastroesophageal reflux disease, ulcers. Whether they use medications like non-steroidal anti-inflammatory drugs, antibiotics. Whether there's a family history of colon cancer, inflammatory bowel disease. Whether they use substances like alcohol or drugs, or smoking tobacco. Whether they have traveled anywhere recently, to assess for any risk of exposure to any pathogens. The figure over here shows the organs that could be affected in the abdomen for any particular region where the patient feels pain. So feel free to take a look at this at your own time. But we'll move on to talk about the physical exam. So obviously, we start with the vital signs. Look for signs of instability, such as whether they're having fever, whether their blood pressure is significantly low, whether their heart rate is significantly fast. We also have to inspect their abdomen. Look for any distensions, scars, masses, or hernias. Also, listen for any bowel sounds by placing your stethoscope on their abdomen, typically in 4 quadrants, so right about here, also here, and then here, and then here. And then it's also good to do a percussion, and if you hear tympany, then it is most likely the buildup of gas. But if there is dullness in any quadrant of the abdomen, then it could mean that there is some fluid accumulating there, or maybe a developing mass. So that could potentially point to malignancy. Also, palpate each parts of the abdomen so that you can check for any tenderness also check for rebound tenderness. And there's all these other maneuvers you could do, such as when you're checking for appendicitis, you can do a Rossing, psoas, or obturator maneuver, as shown over here. Typically, checking for McBurney's point tenderness is used to check for appendicitis, as shown over here. And then you can also do a Murphy's sign check to see if cholecystitis could be taking place, and then costovertebral angle tenderness to see if pyelonephritis might be behind a patient's abdominal pain. Remember that the McBurney's point is approximately located 2/3 the distance from the navel or umbilicus all the way to the anterior superior iliac spine. In other words, it is located 1/3 of the distance from the anterior superior iliac spine to the navel or the umbilicus. And then you could also do a pelvic and rectal exam as needed, especially if the patient is complaining of right or left lower quadrant pain or pain in the hypogastric region. If you are in an emergency setting, it is important to do a risk stratification. So you want to think of the following possible diagnosis first, such as appendicitis, bowel obstruction, perforation, AAA, or ectopic pregnancy. And then, if none of these are occurring, then you can focus on whether some non-urgent causes are taking place. And then, after you do the physical exam and gather appropriate information from the patient, you should order some of these tests. Most importantly, you should order the CBC, because if there's leukocytosis, then that could mean infection or inflammation is behind the abdominal pain. And CBC stands for complete blood count. You should also order a comprehensive metabolic panel so that you can get your electrolyte values, check for liver enzymes to see if the liver is affected, and then your bilirubin to see if something is wrong with the patient's gallbladder. You should also get the lipase value to rule out pancreatitis, and then your C-reactive protein and erythrocyte sedimentation rate is useful for confirming or ruling out inflammation. Your analysis should be ordered when one suspects a urinary tract infection or hematuria. And hematuria means bloody urine, and that can result from the buildup of kidney stones. And then, of course, your beta-human chorionic gonadotrophin test, also known as pregnancy test. This should be ordered for all females of childbearing age. And then you should do a stool study if diarrhea is present. The lactate values can be useful for cases where one suspects mesenteric ischemia or sepsis. And then for imaging, it's good to do an abdominal ultrasound, especially when a patient presents with right upper quadrant pain, gallbladder problems, or some pelvic pain. And then your CT, abdomen, or pelvis with contrast can be preferred for most non-obstetric abdominal complaints. X-ray is useful for assessing obstruction or any perforation. gastric pain, you should consider pancreatitis, PUD, or peptic ulcer disease, and gastroesophageal reflux disease. And I have the different regions highlighted up here. And then if you want to, or if the patient experiences pain in the right lower quadrant, consider appendicitis, ovarian torsion, or ectopic pregnancy. For left lower quadrant, you should also consider ovarian torsion and ectopic pregnancy, but also consider diverticulitis. And then, of course, you would also consider ovarian pathology if the patient experiences pain in the right lower quadrant. For pain in the suprapubic region, or just above where the pubic symphysis would be, so just about here, you should suspect urinary tract infection, cystitis, or pelvic inflammatory disease. And if the pain is more generalized or not specific to any particular region, you should suspect peritonitis, gastroenteritis, or mesenteric ischemia. Once you have tracked down the possible diagnosis, after doing all the appropriate history taking, physical examination, and lab result interpretation, next step is management and possible referral. At the very least, provide supportive care through the use of fluids, antiemetics, and pain control. Antiemetics are medications used to stop vomiting. If infection is suspected, consider the use of antibiotics. And then, if emergent abdomen is suspected, maybe consider a surgical consult. And then, deciding whether to admit the patient or manage them in an outpatient manner will depend on the severity of the pain in the situation. And one more side note regarding antibiotics. You can start with broad spectrum antibiotics if the infection is, or if the source of the infection is unknown, but once you identify the specific pathogen required, you must switch to an antibiotic that is much more narrow in spectrum and that is known to be effective against that particular pathogen. And we're talking about bacteria, so just keep that in mind. So just in summary, you should typically do history and physical, then order labs and imaging, stratify the risk, so consider emergent diagnosis first before non-emergent, or at least rule out those emergent diagnoses first, and then you can manage appropriately. And this is what you would typically do for working on patients with any other types of pain or with any other types of symptoms that they present in their chief complaint. So that is it for today's video. I hope you found this to be a little bit educational. Feel free to add more important and helpful information in the comment section. And like and subscribe for more ASMR educational content like this. I'll see you next time, and please take care in the meantime.